Um, Start of a new academic year and a very busy week or two with grads and other conferences and things going on. So thank you for coming today. It's my pleasure to introduce Dr. Longo, Christopher Longo. I'm not going to go through any bios in any great detail here. Chris is well known to many people on this webinar. He's also spending some time visiting us at Simon Fraser University, and I want to thank him for taking this webinar today. So I'll pass it over to you, Chris.
Thanks, Stuart. So I guess it's good morning to those people out on the west, and good afternoon to those people out east, central and east. So I'm doing something a little different here. Some of you have heard me talk before, and you probably would have noticed that I usually have a whole pile of numbers and I talk to those numbers, and that's kind of my strategy. And so today I'm going to do something a little bit different. Firstly, there's only about 8 slides. So that gives me a little more freedom to just have a conversation. And that also makes you guys sort of the guinea pigs for sort of a new strategy. And so I hope that goes well. So the next slide. So this is just a quick backgrounder. So I'm currently at McMaster University in the Health Policy and Management area of our School of Business. I'm also a member of the Center for Health Economics and Policy Analysis. I'm executive member for Masters in Health Management, program co-lead for ARC's Health Technology Assessment. And I have a couple of other roles, you know, a dad, a husband, a handyman, a teacher, those sorts of things. I've also spent about 16 years in the pharmaceutical industry before I became an academic, and I guess I've been in the academic space now for about 19 years. Yeah, next slide. So this is the one slide that I do have with a lot of numbers in it. I'm not going to go right into that right away, but there's a couple of things you should note. Firstly, this is a PSAFE questionnaire, a questionnaire that I developed. It was actually part of my PhD work that I did back in the early 2000s. One is that a couple of notes I want to make is one, that monthly costs are significant. You can see that on the right side with the national numbers, and I've got the Ontario numbers there. And two, there's a very large increase, well above inflation, between 2003 and 2019. So if you look at that column, it was 1190 back in 2001 to 3 and 2768. So that's a pretty big increase. And I would guess this type of increase is similar in other provinces, but of course I don't have data on that. The 2018 version of the PCA also had a new question on decisions to forego care, which is highlighted here. And these percentages are close to those seen in the US. But to be clear, the severity of these decisions to forego care are not as dramatic as our neighbors to the south, but we'll come back to that a little later. What I do want you to note here, again, my only slide with numbers today, is that this is the 4 primary cancers, that a good number of people took time off work and a good number of caregivers took time off work, and that 41% of the population reduced their spending, and that number jumped to 52% if the family income was less than $50,000. One other piece on this that I'll just talk about briefly is when you think about increases in costs, this translates to about a unadjusted about 111% increase over that period of time. But you know, that only is useful if you reference it to other things. So when I did this talk a number of years ago, I decided to look at 3 sort of staples, if you like. A Honda Civic, because you know the Honda Civic's been around forever. It had a 43% increase over that period of time. The Canadian average income went up by about 15%. And a funny little last example, a 2-liter bottle of Coca-Cola had a 0% increase. You could get it on sale for 99 cents back in 2001. You can get it for 99 cents today. So some things don't go up, but basically unadjusted was 111% increase. If you do a inflation adjusted, it's about a 67% increase. So this is a real significant problem, and I think it's important to frame this as we move forward. So next slide, please. So whose costs? So why do I present it this way? Well, of course, I wanted to make a provocative title, and that's, of course, one of the reasons. So first, costs are shared, right? Governments cover a good portion of it, then the private payers, and what's left over is the patient's and family's responsibility. We can certainly debate if these boundaries are ideal or correct. We can also debate if they're changing. Evidence from the previous slide would say they're definitely changing. And I would note that my data is before COVID. Most accounts suggest that the financial situation got a lot worse during and following COVID for everyone for two reasons. One, government budgets got clobbered by COVID, so they have less room to increase spending. And two, delayed treatments has resulted in a greater number of patients of all types entering the healthcare system with more advanced disease, and in most cases, this means greater costs. So again, is the future going to be better or worse? You know, I'll let you guys decide on that, but my thought would be, I don't think this is getting better. Next slide. Whose life? Why do I ask that question? So if we talk about outcomes, we mostly know that patients by and large trust their healthcare providers to choose the best course of action for their patients. However, the goals of the healthcare providers do not always align with the patients. Let me be clear about that. I'm not being critical of the healthcare providers. I'm merely pointing out that the healthcare provider goals can be different from the patients. This could be because the patient is not able to properly articulate what they want or what they think they want. Partly this is because patients don't really know what to expect, and sometimes even what their family wants or expects. Is the goal to improve the length of life or overall survival? This might be important if the person with cancer wants to see their kids graduate or get married, for example. Is the goal to improve quality of life for the patient or to reduce the burden on the family? Again, taking a more broader perspective. In other words, what impact could it have on the family's quality of life? Is the goal to maintain as much normalcy as possible? Maybe less time in the hospital, treatments that are less toxic, that don't have them at the hospital frequently or in their beds in pain or exhausted. Not all of these factors translate nicely into quality of life measures. You know, this has been an ongoing debate about, you know, what quality of life tool to use and what aspects of quality of life to consider. Most of the work we do today only looks at the patient. It doesn't even start delving into what's the impact on caregivers, family members in terms of their quality of life, the stress that it creates. Again, as the costs increase for patients and more sacrifices are required, effects on diet or other services, et cetera, and the impact on quality of life is pretty clear. But also the increased stress due to the financial toxicity may also impact overall outcomes. This is a very complex problem. I'm sure most of you are well aware of that. Next slide, please. So what are we seeing? So government's responses due to constraints, smaller budget increases, and more decisions to not fund new technologies. I can't speak to every province. I do know in Ontario, the government has grown the healthcare budget almost more than any other area within the government system, like more so than education, more so than environment. But even at that, they're growing at around 1.5% a year. That is just not going to make ends meet, especially with some of the other factors I just introduced. So what that means is they have to make more decisions not to fund some of these new technologies, some of these new diagnostics. So the next payer of choice is a private payer, right? So they also have to figure out how to be more efficient with their spending. So they tend to do things like lower the lifetime caps or increase the amount of copayment or not cover new entries. So all of these things we know where the impact on government and private payers go. Increases, this is all going to translate into increases in patient and family costs. My last bullet here should now be obvious, but please, if anyone sees this differently, do let me know. Is it better or worse? Again, the Ontario example is pretty clear that those costs have been going up. And as I said before, this is pre-COVID, and we know that the system was even more strained during COVID. Next slide, please. So this article, this got me to thinking a little bit about this space, and I wrote an article recently, which I published, looking at the impact of higher patient costs in extreme cases of like financial toxicity on outcomes. I did a rapid review and came up with 3 big buckets related to financial toxicity. One was impact on quality of life. The second one was impact on overall survival. The third one was negative impacts. Third one was specific populations at higher risk. So in this paper, I'm going to go into a little bit of detail here. There was a paper by Hazel in 2020. It's a US study, and they found there was a lower quality of life in lung cancer for patients who had financial toxicity. There's a study by Perrone et al. In Italy that found that financial toxicity resulted in lower quality of life in breast, lung, and ovarian cancers. A study by Delgado-Gay in 2015 saw financial toxicity lower the quality of life in advanced breast, colorectal, lung, and prostate cancers. A study by Fenn in 2014, where financial toxicity lowered quality of life in breast, cervical, and colorectal and lung cancers. A study in 2016 by Lathan, also in the USA, as was the last one in the USA. In fact, all of these were in the USA with the exception of the Italian study, looking at impact in colorectal and lung cancer and the relationship with financial toxicity and lower quality of life. And finally, Zafar in 2015 in the US, showing colorectal and lung cancers had lower quality of life associated with financial toxicity. So that message I felt was very clear. There have been studies done in a number of different places, although US does seem to be the leading country in terms of doing this. And I will say, back in October of 2019, I gave a talk at the ASCO Quality of Life conference in Phoenix, and I had my presentation on financial toxicity, and there were about 15 or 20 other that were from the US. So this problem is much more acute in the US, partly because the systems aren't as good. One of the things that was pointed out to me, which I found somewhat disturbing, was that people who are in the lower socioeconomic status, if they had private insurance, they tended to buy the cheaper private insurance, which generally had a copay of 30%. So they're probably the last people who can actually afford to spend that money. And in fact, they're the ones who are most adversely affected. And so this idea of lower quality of life, a lot of these US studies are focusing on those populations, particularly, who are more likely to be negatively impacted by the out-of-pocket costs associated with treatment. So the next thing was the impact on overall survival. And so there, I looked at a number of different studies. There was a study by Warren. Again, all of these are US studies because I think the problem is more acute in the US. They found that the receipt of chemo and type of insurance predict the use of chemo, and of course that would translate into a reduced overall survival. A lot of the data on overall survival is linked to decisions to forego care or lack of adherence to their treatments or delaying their care. All of those things, as you can well imagine, translate into poor outcomes. So there was a study by Warren that looked at insurance and the prediction of them getting chemo. So again, I just mentioned earlier, some of the less expensive insurance policies have a 30% copay. So there's more often a decision by patients to delay or to forego care. And so obviously that's going to have an impact. There's a study by Ramsey in 2016 that looked at financial insolvency as a risk factor for early mortality. There's a study by Ma et al. In 2021 looking at financial toxicity and survival in head and neck cancers and receipt of radiation. Again, cases where people are either delaying or foregoing those treatments. And then lastly, a study by Klein in 2019, also in the US, looking at those who had financial toxicity pre-treatment and that its correlation and prediction on progression-free survival in non-small cell lung cancer. So again, lots of examples in the literature that suggest that this financial toxicity has a negative impact both on quality of life and on outcomes like overall survival and progression-free survival. And I also want to point out, in some of these studies where they do report numbers, that we have sort of this general issue, I think, with trials in general, and that is we know, for instance, that that we don't get the lower socioeconomic status populations participating in these surveys and in these studies. And so as a consequence, we might see overall, 20% of the population is showing a significant effect related to financial toxicity. But very few of these studies actually try to adjust the effects based on the demographics. In other words, we see an underrepresentation of those people lower SES, and yet we don't necessarily make an adjustment, or at least a lot of the papers don't make an adjustment to say, well, actually this lower SES group represents, 40%, not 20% or 45%. And so in a way, we're understating what those effects are. So the last area I want to talk about is specific populations that are at higher risk. Again, we see some of this. There's, again, some studies listed in this paper, the Kent study in 2013 in the US that showed survivors are more likely to forego or delay care if they're younger, if they're in a minority race, and of course, if they have financial toxicity, which we just finished talking about. In a study by Lau Min in 2020, again in the US, they found the outcomes for minority groups for colorectal cancer were significantly worse. That represented Blacks, Hispanics, and Asians. They also pointed out those populations often had a lower rate of insurance, and many of them didn't speak English. And so they're more likely to get the basic chemo and not the more advanced chemo, which had poorer outcomes. And lastly, a study by Abbott in 2017 in the US that showed that SES disparities and financial toxicities had an impact on their ability to get the best possible care, which translated into outcomes. So I've highlighted these are clinical trials. They tend to miss some of these effects, several reasons. One, again, patients often don't pay for the treatments in the trials. And two, underrepresentation of the low income and the marginalized. So I mentioned number two already, but number one is also worth mentioning. When these are done in trial settings and the patients don't pay, then we don't see some of these effects where they decide to forego care or delay care because it's paid for in the trial. In fact, there's some reasons why they actually participate in the trial. Then we don't see these financial toxicity effects, or at least not to the same degree. There was one paper that I did focus on in this paper about, methods to try to address this problem. This was a paper by Fletcher looking at bladder cancer in 2020, where they looked at some strategies to try to close the gap. And I think there's more and more work in that space, which I think is a very positive sort of outcome. All right, do I have anything more I want to say about that? I don't, so I'll go to the next slide. Why should we care? Actually, that's a bit of a typo. Why we should care is what I meant to write there. And so just to jog your memory again, governments and private payers are scrambling to find ways to reduce costs and save money. I highlighted the Ontario example. I suspect in most other provinces, the issue is the same. They're still reeling from the COVID debt, and they're trying to grow their budgets, but they're not growing them probably as much as they need to. So these problems are getting worse and worse. And as a consequence, and because right now more people are showing up with advanced disease, patients and their families are taking more of that financial burden. Again, in my first slide, I highlighted how it changed from 2003 to 2019. The data is really still coming out for what happened after 2019. As we know, COVID hit Canada in early 2020. And, I think we have another outbreak right now, although I think the expectation is it'll be a much more mild case in terms of compared to what we've seen in the past. And now that most of us have been vaccinated. And again, we're seeing that it's more significant in disadvantaged populations, the low SES, the the Blacks and Latinos based on US data, and I would argue the Indigenous populations in Canada. So again, we've already talked a little bit about the fact that we have an underrepresentation of some of those populations in our trials. But for me, I think, this decision to forego care, this reduction in quality of life, this suggests that the outcomes and the financial situation are going to be a lot worse, right? Again, I've mentioned the trial does not reflect this reality. And by extension, being health economists, it's going to have an impact on the ICER, right? And so what I started asking myself is, right now we have a hypothesis that they do, but we don't really have a systematically analyzed set of data to see if this is indeed the fact, and of course, how large that effect might be. So I personally think it's worth investigating. I guess that sort of moves me to my next slide. So basically, this paper got me to thinking, right? I put some of these down in my slide deck. It is not that well formulated yet, but it seems to me we should be making some adjustments to how we value these new treatments. So I spent a number of years, a total of 8 years, I guess, between the OSCCD, which is the Ontario Steering Committee on Cancer Drugs, and PCODR, which is the Pan-Canadian Oncology Drug Review Expert Review Committee. And one of the things we noted was that the burdens related to diagnostic tests and expensive treatments, and they're partially borne by patients and their families. And these issues come up often enough to be of concern. In other words, as we're reviewing these drugs, this point gets raised in, I'm going to say, just throwing a number out there, probably 70% of the cases. Obviously, these are going to vary by province, with many provinces only covering the elderly and those without access to private health care. Just to be clear, private health care often has copays. I mentioned that before, and I mentioned the example from the US where in some cases it can be as high as 30%. In Canada, I think the numbers are a little bit better, typically 10 to 20%. But sometimes some of these new therapies, if they're not covered, are $5,000 to $10,000 a month. So a 20% copay is not exactly trivial, especially for people whose family income is below $50,000. Diagnostics can often have a higher copay of like 50%, and generally the coverage there is also lower. So the copay there might be as much as 50%. So some of these new ones, as I understand, are about $1,000 for diagnostics. So again, that could be a pretty significant hit for patients as well. So again, in a perfect world, we would integrate the financial toxicity effects into the calculation of the ICER. That would hopefully drive down the cost of new treatments or encourage industry to broaden their support programs for low income or high need patients. This would require a process or mechanism to quantify the effects of financial toxicity on quality of life and downstream outcomes. I think it should be done. There might be a question as whether there's political will to do it. I am not privy to some of those backroom conversations, so to speak. So I think I want to move to the next slide, which I guess is my final slide. So I really only have used half the time, which means that we have a lot of time for questions. Where do we go from here? I think perhaps we need a better strategy to identify those at high risk for financial toxicity. I have some ideas about that. I've shared those in some previous talks just to throw some of them out there. One of the things a lot of social workers or nurses, when they're meeting with patients for the first time, ask them about financial toxicity and how their finances are. And unfortunately, a lot of patients not really fully understanding how significant those costs might be, say that they're fine. But usually 3 or 4, 5 months in, they start to realize the costs that they have to spend are much higher than they thought. And so I've always felt that this is an ongoing conversation with patients. You don't just ask them once, you ask them several times during the course of their treatment. If they're still doing fine, more exploration on financial toxicity and outcomes. Again, I saw a body of literature here, mostly in the US. I haven't seen anything in Canada yet. Perhaps we need to be encouraging people to look at some of these things in a clinical trial setting, or in a real life cost effectiveness setting. Include an adjustment for efficacy based on decisions to forego care. Again, alluded to that. If people are delaying care or foregoing care, then it's pretty clear that's going to have an outcome on their overall survival. And, you know, you could make an argument that all of the above should apply. So probably a bit shorter talk than maybe you were expecting, but I guess that gives us more time to dialogue. I think my next slide is just some of the articles that I've used as the basis of this, if you flip to the next slide. So I only used about half an hour. So maybe a little bit shorter than we thought, but happy to entertain 30 minutes worth of questions.